Hi, my name is Kelsey Schwabeck and I'm a PNP and DNP student, and I decided to just do something a little different and give a little presentation just to explain the model of Corbin and Strauss's trajectory of chronic illness, and just go through the different stages and tell you guys a little bit about why I'm interested and why I decided to do this topic. So I wanted to first just start with talking about illness versus disease. So a disease is a pathophysiologic process, and there's some sort of abnormality within the body. And an illness is more of a social and psychosocial phenomena. It can be directly influenced by the disease, but it involves more of the patient's perception and their experience within the illness. So chronic illness is then defined by a few different organizations. So by the National Center for Chronic Disease and Prevention and Health Promotion, it's defined as an illness that's prolonged, does not resolve spontaneously, and is rarely cured completely. Then there's the chronic illness as defined by the World Health Organization, which is any disorder that persists greater than 3 months and affects that person either physically, emotionally, intellectually, vocationally, socially, or spiritually, or all. So chronic illness can be anything from asthma that's well controlled on an inhaler or oral medications. It can be diabetes, which is pretty extensive lifestyle, diet, and medication regimens. It can be congestive heart failure, which is a multi-system failure. So there's quite a variety of chronic illness, and it's up to the provider to know that patient and know what stage they are in what we'll go over of the trajectory of chronic illness. And just so you guys kind of get the big picture that these are different phases or stages within this trajectory model, and you really can go in and out of each stage. So it's kind of like a roller coaster of chronic illness, and some people go through chronic illness in a very short span of time and then get into the deterioration and dying. Or some people live with a chronic illness their entire life, and it really has a lot of peaks and plateaus. So that's kind of how we want to look at things, is that you're always going in and out of these different stages. So the 8 phases or stages that we'll talk about, I'll give examples of congestive heart failure patients and an example of what that phase could look like in those patients. And you can really apply it to a variety of patients. So there's the preventative phase. Now, sometimes we see patients in this phase and sometimes we don't. So this is before the course of illness begins. So typically, this could be seen in a primary care of a patient that's, say, very obese and has risk factors for CHF but doesn't quite have it yet. And this is where we can intervene and make a difference with primary prevention. That's the preventative phase. So then the second phase is the definitive phase, or the trajectory onset. This is where the signs and symptoms are present and we start to realize that there could be an illness present here. This is where we do a lot of the testing and a lot of looking at those signs and symptoms. So does the patient have edema? Do they have hypertension that's uncontrolled? Things like that. And then we would intervene with different treatments. And this is where I think as a nurse practitioner we can add a benefit here, because we can add in a lot of holistic treatments as well as medication treatments and lifestyle changes. So then sometimes they could go into a crisis phase. Now this could happen, right after they're diagnosed. This could happen years after they're diagnosed. And this is any kind of life-threatening situation. So an example could be that this patient has an MI, and it could jerk them, and they have this crisis phase, and they are not doing well. So then we would, as the healthcare provider, they'd probably be inpatient at this time, I would assume, and then they would transfer, and get a little better. Then they could have an acute phase, which is the next phase, but remember, these are all intertwined. It can all change and happen at any time. So this is the active illness that requires hospitalization, but it's not as acute, it's hard to use the word acute in the acute phase, but it's not as life-threatening as the crisis phase. So the crisis is more life-threatening. The acute phase could be that now this patient goes into more stage 3, stage 4 renal failure, and they really need to be taught on that. And a lot of patients don't realize that they have that disease. And there was one article that I was reading that is about caring for patients with congestive or chronic heart failure and using this model. And it was interesting because they talked about how the patients manage the disease based on how they perceive themselves and how they perceive that disease. So a lot of the times, patients don't really realize that the kidneys are really related to the heart, what's going on with that disease process. So it's an important educational piece for us as providers to teach the patient and have knowledge so then they can perceive that and have better self-management of their chronic illness. So then there can be the comeback phase, and technically it's like the 5th phase, but this can be anywhere within the phases. This is where they have an increased adherence to medications, increased adherence to different lifestyle changes, possibly maybe they'll lose a little weight. And this is great. We want to really keep them in this comeback phase, obviously, as long as we can, and always have them have better adherence and better self-management of themselves. So then they get into the stable phase, say that they've done good with that comeback phase and they're in a stable phase and the illness is controlled by whatever regimen you happen to have them on. So this could be that they're now using the DASH diet for their kidneys, they're taking their ACE inhibitor every day as prescribed, and they're really, trying actively to lose weight and stay exercise and healthy. So that's the stable. And then there's the unstable phase, which is they're not controlled, but they're not requiring hospitalization. So this is their slip. They're not really doing what they're supposed to. Maybe they're taking their pill every other day, or, and this could be for a variety of reasons. We really have to look at, are they not following the regimen because they just don't want to? Or are they not following it because they can't afford to pay for the medication, or things like that? So then there is the deterioration and dying phase. And most of the time, when you get into this phase, typically, you're in that phase. You don't really move too much in and out of this one, obviously. So there's progressive deterioration in your physical and mental status, and basically you have an increased disability now. Your chronic illness has worsened to the point where you cannot do your daily activities, your quality of life is down, and that really is a hard stage, but we can still help with that stage too. And we have to understand the resources that are available for those patients. If they're not going to do well, they're not going to have any more comeback phases, but they still want to have a good death, and that can still happen. And then the final one is death. So as a nurse practitioner, we want to keep the patient at that stable phase, and wherever that may be within their illness. We don't want to increase their disability. We want to keep them so they're having a good quality of life and still being able to do the things that they did before their diagnosis of chronic illness, whatever that happens to be. And we don't want them to become hospitalized. So next, I'm just going to import a picture of one of the models as well. It's the construct and trajectory of chronic illness theory and how those intertwine within the phases.